Hey, it's week 3 of everything you need to know about treatment planning in just a couple minutes. Okay, so this week we're going to talk about depressive and bipolar related disorders, or I like to call them diagnoses. I don't call them disorders, but that's just semantics for you. What you needed to do, look at the what's new and what's due, and then remember that next week there's the week of 2-5, you don't have class. All you're going to be doing is working on those papers, writing them up. Hopefully you've already interviewed somebody or you're in the process setting that up. But get that done and write that up. Okay, so then when I get back, I get flooded with a bunch of papers to edit. That'd be perfect. But I will be out of the country. And so what happened last time was that I had really, really spotty Wi-Fi. So just note that. You can always try texting or emailing, and I will do my best. But just note that that's a potential occurrence. Make sure you go over that rubric. I grade everything according to that rubric. So really, really focus on making this sound like a conversation, like you're reading something at an award ceremony about what a person has gone through and what they're going through. And don't focus on, do not write question followed by the answer, etc. Okay, so check out my PowerPoint. No, not my PowerPoint. My video on that also on D12. Okay, so we'll go through the mental status exam is super important because you will use that if you have someone in your thinking, okay, we're doing talk therapy, but for whatever reason, you're not able to discern what they're trying to get to. Sometimes we think, oh, either this person is maybe not sober, or maybe experiencing delirium, or maybe having some sort of prescription mess up, or maybe going through a stroke. We need to know those things because we cannot do talk therapy with someone who's not cognitively able to do it in that moment. Okay, so we would do the mini mental status exam, and if they scored accordingly, we would say, okay, we're going to go ahead and get you to a medical facility to get you the treatment that you need, and we'll circle back when you're ready. Okay, so that's super, super important. Even if those questions seem kind of weird or easy, they're very, very important. Okay, so we talk about that a lot in crisis class, and we'll go over that more too, but take a look at it. There are scoring instructions, all of this stuff. Okay, so major depressive disorder, MDD, is like 6.5% of the population, tons and tons of folks, and that's underreported because a lot of folks don't go to get diagnosed. Okay, so major depressive disorder is it's higher in folks who identify as women, but again, all of these statistics can be misreported because we tend to see folks who identify as men maybe not going for help. So just know all of that stuff. Okay, so major depressive disorder, take a look at that. You will be using your DSM-5-TR anytime you're diagnosing. So you would be doing an assessment, right? An assessment tool, and then you'd be looking at the DSM-5-TR and making a judgment accordingly. Okay, so look at the PowerPoint. We see in just the MRI of the brain that a normal brain, or a brain that is not expressing or experiencing depressive symptomology, looks much different than a brain that is experiencing depressive symptomology. So we see it scientifically. We see trauma impact this, all that stuff. Okay, so how do we treat it? We are going to look at what are you experiencing. We're going to look at strengths. What do you have going for you, right? Maybe you really love to do things that will automatically get you feeling better. And so let's look at that. Or maybe you are inspired or motivated, or have a friend who's also motivated to do this. Maybe you like to read. We can do bibliotherapy, but we're going to help them with their treatment in that way. The assessments I have listed, whatever clinic or organization that you work for, they will have their assessment tool that they really like the best, and so you'll use that. But in assessment class, you'll probably go over the Beck depression because that's pretty common and it's a really short assessment tool. Often folks benefit from medication. Some folks are against medication, and that's totally fine too. We just provide them with psychoeducation about it, and then help them with things like, okay, well, if you are aversive to medication, cool, let's talk about the natural benefits that you can get from, let's say, sunlight and movement and all the things that depression doesn't want you to do because it works against that. I put in a slide about cognitive behavioral therapy, mindfulness therapy, and behavioral activation, just so you could kind of see, okay, if that was me, if that was my theoretical orientation, how might I approach it? And so kind of read through it and see which one you're like, yeah, I'd do that, or what? And then you can always search for more information on the www World Wide Web. We have persistent depressive disorder, which is very similar, but then it's like longer, right? So at least 2 years, which is really, really tough. 2 years of straight depression and that person's coming to you, we need to celebrate that. Like, great job getting out and getting help. Like, let's figure this out so that we can ameliorate some of those tough symptoms. We have premenstrual dysphoric disorder, the PMDD, and that occurs with folks who experience periods or PMS symptoms. So, you know, PMS gets a bad rap in social media. And so sometimes folks who experience PMS are resistant to think that is something worse because we kind of chalk it up to like, of course you have cramps, of course you're moody, of course you're exhausted, of course you have nausea, of course you have constipation, whatever it is. PMDD is different and it's to be taken seriously. So if you have someone come in who experiences periods, we got to talk about that, okay? Disruptive mood dysregulation disorder, we see that a lot with like kids. They don't want to wait for something. They can destruct stuff. They're like irritable. They're angry. They can get aggressive. They react negatively to stuff. So these folks come into the counseling office and you think they have been probably asking for help in the ways that are the toughest for folks to reach out to them. And so we want to be that person that's empathetic, patient, that we respect them, that we say this has got to be tough for them too, and really work to help them. So we think about how we treat that too, and I gave you some different ideas there. Bipolar 1 and bipolar 2 are two different types of diagnoses differentiated by the experience of hypomania or mania. Mania with bipolar 1 and hypomania with bipolar 2. Okay, the way you remember that is hypomania is 2 words, hypo and mania, and bipolar 2. Get it? Yeah. You're welcome. Okay, so I gave you lots of videos just to kind of get that. If you're interested in something further, this is an online class, so hard. But take a look at that. Again, the media distorts what bipolar 1 and 2 look like, and so we really want to make sure that we are well informed. Okay. So then we go to the medication. Anxiety is probably the number one reason that folks go to counseling. Anxiety is a big deal, and it can feel like a heart attack. Panic attacks definitely feel like they're dying, and so we want to take all of that stuff seriously. We don't ever want to say, oh, it's just a panic attack. We always want to err on the side of caution and send them in, okay? Like, we would rather do that than be wrong. So, but also giving them tools to help them through that panicky breath or the rapid heartbeat or all of that stuff, okay? Other things that cause anxiety. So if they're experiencing a lot of anxiety, but they're doing mindfulness or breathing or getting enough sleep, look at things like, are you taking diet pills? Are you taking an inhaler? How much caffeine do you drink? And caffeine is in other things like chocolate too. Are they using cocaine? Are they using Afrin, steroids? That could be prednisone. That can be also like harder steroids, any type of stimulant. Do they vape? Are they a cigarette smoker? Do they use alcohol? Alcohol actually causes anxiety, even though they think it does the opposite. Lots of diseases, concussions, all that stuff. So look for those other things too. What we want to remember the most is that people came to get help, and we are there to help them, and we want to empathize with them. We want to give them patience and respect and figure out what is it that you struggle with this, and how can we work with what you have going for you to help you out so that we don't have to keep going through this. Come back and see me. Always text me or call me or email me if you have any questions. Thanks for being you. And hey, week 3, treatment planning. We only have 12 more. Take care.